Welcome to the webinar on supporting families affected by opioids and other substance use disorders through infant and early childhood mental health consultation. This webinar is brought to you today through the federal leadership of the Substance Abuse and Mental Health Services Administration in partnership with the Administration for Children and Families and the Health Resources and Services Administration. And you can see we have a disclaimer here that talks about how the content, opinions, and views are not necessarily those of the group that's bringing this to you. We have 3 objectives for this 1-hour webinar. The first one is to understand how the use of opioids and other substances in families affects the social and emotional development and the cognitive skills of babies and young children. We also want to understand how opioids and other substance use in families affects the attachment relationship between the caregivers and the infants. And we're going to identify strategies that consultants use to support the work of home visitors as they work directly with pregnant and parenting families who may be impacted by substance use. We have 3 speakers today. I'm going to introduce those to you. Dr. Ira Chasnoff is the president of the NTI Upstream. He is a pediatrician and a professor of clinical pediatrics at the University of Illinois College of Medicine. We have Leslie Schwartz with us today from the Illinois Governor's Office of Early Childhood, and she is the McVie Project Director, McVie standing for Maternal Infant Early Childhood Home Visiting. And then my name is Linda Delamata. I'm an expert mentor at the Center of Excellence for Infant Early Childhood Mental Health Consultation. Thank you all for joining us. It's pretty clear that we have a big problem with substance misuse, and in particular with opioids. It's such a big problem, we're calling it a crisis. It is impacting our families. People are losing their lives. People are going to jail, and if they have infants and young children in their lives, children are there without the supports that they need in order to grow and develop. It takes all of us to join in and collaborate to decide how we're going to do this support to families in order to help this issue. Today we're going to talk about consultation and home visiting and how that can be one part of the problem. It's not a fix. It is, however, a way to help identify those who might need help, a way to open those conversations, and how we can support home visitors as they navigate this world that they're experiencing as they do their work. Although substance use or misuse may be something that the adult is involved in through their own behavior, it impacts everyone that's around them in a really big way. When we look at the children, it disrupts their security, and security is important as a child learns and grows. It interferes with the parent-child relationship. And we know that the relationship is how children get their social and emotional skills, how their cognitive and physical skills develop. It is one of the most important pieces of how we help children. So we're going to talk today a lot about relationships. Here are some things that we know about opioid issues. And these are just some facts that relate to the children. The number of babies born with NAS or neonatal abstinence syndrome is increasing rapidly. The number of babies under the age of 1 who've been removed from their home due to substance use doubled between 2005 and 2013. And then substance misuse accounts for almost half of all of out-of-home placements for children under the age of 1. There are so many complications that go with the use of substances and with opioids. Complications that might involve child welfare, that might involve the criminal justice system, might involve incarceration, treatment. All of those things affect the child as well as it affects the family. And so we talk today about ways that we can work with those who support the families. So substance use impacts all the adults in the family, not just the user. If your mother is using in the family, it also impacts the people who are also in that family and working with the child. So it could be the partner, it could be a grandparent, it could be a sibling. It is all people who are involved. Sometimes when we treat that adult, we focus only on that adult and the substance use issue. But what we know is because it impacts the whole family, we should be looking at the supports to that child that are available in all parts of their life. So we should also be including their child care. We should be including their preschool. We should be including the home visitors who work directly with those children, and any services that are available should include all parts of that child, that person's life, the whole family. What we know about home visitors is that are right there in that family. They focus on the needs and the development of that child. And what they do in their work is to look at everything that impacts that child's growth and development and to promote the healthy ways of interacting, to promote ways to help that child grow and develop, but also to identify and address those that get in the way. So home visitors are uniquely positioned to take a look at this particular issue. This baby's brains develop so quickly. These facts are amazing. In the first few years of life, 700 to 1,000 new neurological connections form every second. Each second that child's brain is growing and developing. They just grow at lightning speed. And this critical time is so important to brain development and everything that follows. So kids grow and learn by processing everything and everyone that happens around them. They react to their environment. They react to the relationships that they have. That's why environment and relationships are so essential to children's growth. Home visitors know this, and so they're in the homes of the families that support them on a regular basis. And they work themselves to establish relationships. So sometimes they're in those homes weekly. They might spend an hour every week with the family, and they become a part of conversations about how to help that baby grow and develop. And they are witnesses to things that are going on with that child and the things that happen within their home. Together, they work with the family to look at the cognitive, physical, social, and emotional development of that child. They understand the importance of relationships, and they use their own relationships to connect with the families. But they take a look at whatever stands in the way of that relationship, and then they attempt to address what those things might be. So many times home visitors do screenings. In fact, they do screenings on a regular basis. They'll be doing screenings on child growth and development, and that includes social and emotional development. They might use the ASQ or the ASQSE. They do screenings on maternal depression. They do screenings on partner violence. And then one of the other things, and the reason that we're talking today, is that they do routine screenings on substance use. So your home visitor is on a regular basis taking a look at what are the things that interfere with that child's development, including substance use. Your mental health consultant then is someone who helps support that home visitor. They are there to help that home visitor focus on how best to help the family. So mental health consultants aren't there to provide therapy for families or children. They're there to partner and collaborate with the adults in the child's life. So in the case of home visiting, that's who they work with. They work with the home visitor, and their goal is to help build their capacity to strengthen and support that healthy social and emotional development of children. Home visitors frequently work with either pregnant or pre-birth all the way up to age 3. And this is that critical time for brain development. So a mental health consultant can be integral to addressing the issues that interfere with that brain development. Mental health consultants are not direct service providers, but instead they work with the home visitor, and they're supporting them so that they can do their very best for the family. The mental health consultant then brings the lens of mental health and relational behavioral health to the home visitor. One of the things that we do is to help to understand how the issues related to substance use and opioid use impact that family. In addition, we give them a safe place so that they can focus on anything that they need to in order to identify issues. So let's say we want to walk through the screening tool about substance use. Sometimes it's pretty simple, and that screening tool doesn't identify anything that would be of concern, and that works out real well. But when some things show up, You have a mental health consultant that a home visitor can sit down and talk to about, here are some things I saw in that screening tool. I'm not sure what's the best step. Can we walk through what might be happening? Can we talk about what I should do next? Is this a place where I need to make a referral? Or is this a place where I need to keep the conversation going and ask more questions? So it gives the home visitor a place to walk through all of the issues that they're addressing, and then to have a reminder that the focus is on secure and nurturing relationships in combination with the environment so that we have that healthy brain development and social and emotional growth. So the mental health consultants are a support to home visitors. And home visitors see and experience things that can be very difficult. And a mental health consultant is there to help them process through and walk through issues. It gives them a time to reflect on what's going on and keep themselves non-judgmental so that they can keep those conversations going with the families, so that they can help identify and support the mom as that mom might need some assistance in getting support for her issues. And they help with words, because sometimes it's hard to know what to say and how to get into that. Let's say that I'm a home visitor and I'm working with a young mom, and this young mom is using a substance of alcohol, and she is pregnant and she is drinking. And I've had a conversation with her, and I've talked about how this can interfere with the health of her baby, with the relationship with her young child, and that it's a real important thing for her to consider reducing or eliminating the use of alcohol. And then I'm in her home the next week and she's still using, and I talk about it again. And so what might be happening with that home visitor is they're getting frustrated. They're thinking that they're not having an impact. They're not sure what to do next. They can sit down with their home visitor and talk through this situation and then find words that remain supportive and non-judgmental so that we can open that channel so that we can help that mom get the support she needs. Because what you might want to say is, you need to stop drinking. But what you really need to say so that you are opening that conversation might be something like, I am concerned, which gives a different message. It is the relationship between the mental health consultants and the home visitors that provides that support and safe place to talk. And it is the relationship between the home visitors and the families that provide that safe place to take action. This is a collaborative relationship. There's not one person telling another one what to do. This is how we work together in partnership to make some things move forward. Mental health consultants provide also assistance and referral. So let's say you walk through all of the issues that you feel we can do in home visiting, and the next step is going to be, let's refer that person to treatment. That is so hard to do sometimes. There needs to be many steps taken. And your mental health consultant can help with what we call a warm referral, make the connection with the next step, talk to the agency that will be receiving the referral, make some connections between them, potentially set the path going so that this isn't a referral where no one then gets back to them. So having that warm referral makes this a much easier process. I am going to turn this over to Leslie Schwartz now to talk about the Illinois McVie work. Leslie?
Thank you, Linda. Illinois has long valued the role of infant mental health consultation in home visiting. Since its inception, McVie in Illinois has funded infant mental health consultation and offered it to all of our programs. Concurrently, at the inception of McVie, we also recognize the importance of screening prenatal mothers for substance abuse, depression, and domestic violence. To that end, we collaborated with Dr. Ira Chasnoff to train our home visitors on the 4Ps Plus. The 4Ps Plus is a validated screening tool for prenatal mothers at risk for tobacco, alcohol, illicit drug use, depression, and domestic violence. After our home visitors began integrating the 4Ps Plus screening tool, it became apparent that they would benefit from ongoing support around using the tool. Not only did they need support on how to talk to mothers about the results of their screen, but they also needed to understand and address their own biases. We knew that the infant mental health consultants could provide just that in all the ways that Linda just described to you. We decided then to cross-train the infant mental health consultants on the 4-Piece Plus, and we connected them with Dr. Ira Chasnoff, who implemented a train the trainers so that the consultants could train the home visiting programs. Cross-training the infant mental health consultants in the 4-Piece Plus was not only a good fit given their expertise in mental health and substance abuse issues, but it also made sense logistically. The consultants already had established relationships with program supervisors and home visitors, and they also already had regular scheduled in-person meetings. Essentially, the consultants could bring the training to the programs, and this eliminated any barriers related to traveling to training or waiting for the next available training, because the training could be brought to the programs where they wanted it and when they needed it. It was also helpful when there was staff turnover because the consultants could get new staff up to speed much quicker. This arrangement with the consultants has worked out so well in Illinois that we expanded the curriculums that our infant mental health consultants are cross-trained on, and even asked them to develop specialized curriculums on topics that home visitors were interested in. So in addition to the 4-Piece Plus, the infant mental health consultants in Illinois can train home visiting programs on the Mothers and Babies program, which is a depression prevention curriculum we implement in partnership with Northwestern University. The infant mental health consultants also train on the Futures Without Violence, Healthy Moms, Happy Babies curriculum, which addresses intimate partner violence. And we had the infant mental health consultants develop their own training for home visitors working with parents with special needs. We look forward to continuing this partnership between Infant Mental Health and Dr. Ira Chasnoff, and it is at this point that I get to pass it on to Ira to discuss the role home visitors play in prenatal opioid exposure.
Thank you, Leslie. It is my pleasure to be with all of you today. I've been working with home visiting programs in several states and have found that home visitors really can get to the heart of the matter, especially when we're talking about very high-risk families affected by depression, domestic violence, substance use. Now, I've been asked to talk about the neurobiology of prenatal opiate exposure, but I want to reiterate a very important point. As we discuss the impact of opiates, we have to understand and remember that children grow and develop in the context of relationships. And so we have to look at opiate use and prenatal opiate exposure through that lens of relationships and ask how the exposure does affect the development of a relationship between the mother and infant. We're looking at this from the perspective of attachment, and let's make sure we understand what attachment is. Attachment is the interconnectedness between human beings, and it requires each of those human beings to read the other's cues and to respond appropriately to those cues. In the context of the mother-infant relationship, the important thing to remember is that attachment is not the sole responsibility of the mother, but the infant must have those same capabilities. The infant must be able to read the mother's cues and respond appropriately to the mother's cues. So an infant affected by prenatal substance exposure starts with one strike against him when it comes to fulfilling his role in attachment. We're going to begin our discussion on the placental side. We're going to talk about the mother. The mother must be accessible to the infant and responsive to the infant. Now, in our research over the years in looking at this issue, we've identified 6 factors affecting relationships in women who are chemically dependent. The first is negative heritage. We learn to be parents from our own parents, and in many cases, as documented through the ACEs studies, a woman who is using substances as an adult often came from a family in which there was substance abuse, domestic violence, mental health difficulties in the family. And so that right there sets her up for having no role model when she was a child, no role model for positive parenting. We know also that many of the women come to us with a significant history of trauma. In our own research with this population, as well as the research of many others, we find that at least 90% of women who are using substances during pregnancy have suffered significant early trauma. Children who grow up in homes that have substance abuse or domestic violence in the home We look at those families as avoidant families because they operate outside the context of systems. They avoid getting involved with healthcare systems and other treatment programs. And so a child who grows up socially isolated, learning to keep secrets, is going to grow into an adult who is socially isolated. The other issue is cognitive functioning because a lot of our work is psychoeducational. To discuss this, I want to give a good example of how substance use can affect cognitive functioning in the adult. The MRIs you see here, the two top and bottom on the right, are a woman with chronic alcoholism. I know that our discussion today is opiates, but you have to recognize that the most common form of substance use by women is polydrug use. So that, again, from our data, we find that about 81% of women who are using opiates are also using alcohol, tobacco, and often marijuana. Now, the two on your left, top and bottom, are normal MRIs, two cuts looking from the back toward the front of the brain. And I'll draw your attention in the top one on the left to this open space. This is called the ventricle. So these are the ventricles. And the ventricles are open spaces in the brain through which spinal fluid flows to nourish the brain. So top and bottom. Now, if you look to the right, this is a woman with chronic alcoholism. And the first thing you see is the open space that the ventricle has expanded quite a bit. This is because alcohol kills off brain cells. And what that produces, as the brain cells die off in the periventricular area, you get expansion of the ventricle. And this affects global cognitive functioning. In the bottom two, on the left is the normal, and what you can see here, this structure right here, is called the corpus callosum. The corpus callosum is responsible for moving information from one side of the brain to the other. So that's how you connect the two sides of the brain. If you look at the bottom right MRI, the same cut through the brain, but you can see significant thinning of the corpus callosum. What this means clinically is that there is difficulty in connecting the right and left sides of the brain, so that the woman has difficulty making decisions, looking at long-term consequences, understanding the consequences of behavior. So these are all aspects of behavior that can be affected by chronic alcoholism. The other thing we know is that women who are using substances have a significantly higher rate of co-occurring mental health disorders than do men who have substance use disorders. And we see that psychological functioning is affected. The two diagnoses we make most commonly in pregnant women who are using alcohol and drugs are depression and borderline personality. Now, depression, it would be pretty clear as to the effects on that maternal-infant relationship. But let's talk about borderline personality just for a moment. Borderline personality is when the individual is very egocentric, looks at everything that happens in the world as it affects him or her. There's a lack of empathy. There's no understanding of what they do and say, how that affects others. And so you can imagine now a woman who has a borderline personality, imagine how that affects her responsiveness to the infant. And then finally, the sixth factor is substance use. Now, this is the neurobiological cycle of attachment. And I'd like to start up here where the red asterisk is, and we're going to follow this cycle around. The neurobiological basis of attachment resides in the dopamine system and the oxytocin system. Dopamine is a neurotransmitter, and dopamine is key to regulatory behavior. And you're going to hear me talk a lot about regulation. The other is oxytocin. Oxytocin is produced in the brain by the hypothalamus, and it's often referred to as the cuddle hormone. That is the hormone that drives attachment, and when you make an attachment with another individual, whether it's an infant or another adult, that fires off oxytocin. So if we take the typical situation, we have an adult woman with properly functioning dopamine and oxytocin pathways. She becomes pregnant, and both her prenatal and postnatal caregiving environment are providing dopamine and oxytocin responses to her growing attachment to her fetus. This allows the fetus then to begin developing appropriate dopamine and oxytocin pathways, so that once the infant is born, he is born with appropriate neuroendocrine development. That results in infant attachment behaviors, which of course drives increasing oxytocin and dopamine responses. You have ongoing environmental influences, but this infant grows into an adult with an intact attachment system, so that when that individual is an adult, we're ready to start the human cycle all over again. Now, the difficulty we get into is that chronic administration of drugs of abuse, such as opiates or cocaine, substantially reduces oxytocin levels in the hypothalamus. So now one of the key pathways of attachment has been affected by substance abuse. And where that leaves us in the cycle then is that if substance abuse disrupts oxytocin levels, and so you get decreased oxytocin produced in the adult brain, during the prenatal and postnatal period, the mother's oxytocin levels are reduced, which means there's decreased stimulation for the development of the infant's oxytocin systems. You get impaired attachment behavior, ongoing environmental influences, so that as that infant grows into an adult, he has an attachment system that has been hampered by his prenatal exposure to substances of abuse. And so you can see that just looking at oxytocin responses, we have a biological basis to inhibiting the appropriate attachment. And so let me remind you, children grow and develop in the context of relationships driven by the oxytocin hormonal system and the dopamine receptor system. So let's talk about the infant now. We're going to talk about the biological basis of the effects of prenatal drug use on the catecholamine system. Now, the catecholamines are also known as neurotransmitters, and the key neurotransmitters are dopamine, norepinephrine, serotonin, but we're going to focus on dopamine. We've already been talking about the importance of dopamine in the attachment cycle. Related to substance abuse, dopamine, as I said, is the regulatory center of the brain, but it also is the pleasure center of the brain. So, for example, when you eat food, you fire off dopamine. That's why we enjoy eating so much. The reason drug users use drugs is to get that dopamine effect. For instance, with methamphetamine, methamphetamine acts at the presynaptic junction. The electrical message of nerve stimulation travels down the pathway, is picked up by the dopamine. The electrical message is carried across the nerve gap. The dopamine releases the electrical message, and then dopamine circulates back to the proximal nerve ending. This is called reuptake. So that's why we never run out of dopamine, because of this reuptake process. Now, methamphetamine causes excess release of dopamine across the nerve gap. So that's how a person gets high from methamphetamine. Cocaine, there's a normal amount of dopamine that crosses the nerve gap, but then cocaine blocks dopamine reuptake. So you get excess dopamine at the postsynaptic junction. That gives you the high. Today's conversation is about opiates. Opiates act on the midbrain, and what happens if you look at the green representing an opiate, morphine, opiates attach to the opiate receptors, which is the yellow here. When the morphine, in this case, attaches to the opiate receptor, this decreases the release of gamma-aminobutyric acid, GABA. And this sends a signal to release more dopamine. And so morphine, by blocking dopamine receptors, stimulates the brain to release more dopamine. And again, that's how you get the high. So what are the effects of prenatal opiate exposure? Well, we've already said that dopamine is the regulatory center of the brain. It's the pleasure center of the brain, but dopamine also acts on smooth muscle, so that anytime someone uses any opiate, as well as tobacco, cocaine, methamphetamine, one of the first effects is tachycardia, an increased heart rate, because the heart is made completely of smooth muscle. The other major organ of the body that is present in half the population of the world is the uterus. The uterus is all smooth muscle. So when an individual uses any of the substances that we've been talking about, it stimulates uterine contractions, which is why you get increased rates of preterm labor and delivery in infants whose mothers use any of the variety of substances. You also get high rates of low birth weight, low birth length, a small head circumference, increased rates of stillbirth, and increased rates of sudden infant death syndrome. So these are the basic medical effects of prenatal opiate exposure. But where I want to turn is to neonatal abstinence syndrome. And I want to make sure we're all talking about the same thing. There are some key questions I would like to address. What is true neonatal abstinence syndrome? How does this differ from neurobehavioral difficulties in an infant? What factors might affect diagnostic labeling? And when it comes down to it, is it really that important to differentiate NAS and neurobehavioral difficulties? So let's talk about neonatal abstinence syndrome. NAS is defined as the signs and symptoms that occur when a newborn prenatally exposed to opiates experiences opioid withdrawal. From the time the definition of neonatal abstinence syndrome was set, through publications by the American Academy of Pediatrics, the American College of Obstetricians and Gynecologists, multiple other organizations, it has always stated that it's prenatal exposure to opiates that produces neonatal abstinence syndrome. Neonatal abstinence syndrome can be present at birth, or it can present as much as 24 hours after birth, depending on when the mother last used her opiates. It usually peaks at about 3 to 4 days, and in its acute phase can last up to about 6 weeks. But we published an article several years ago that describes what we call the subacute phase of neonatal abstinence syndrome, and that can last up to 7 to 8 months. Now, just for a moment, let's turn to neurobehavior. In a nutshell, neurobehavior is the way we as humans interact with and respond to both the internal and external environment. It's driven by the operation of the nervous system and is expressed through behavior. The reason I bring this up is that there are a variety of non-narcotic drugs that have been shown to cause psychomotor behavior in infants that looks like, on the surface, neonatal abstinence, and has been described as neonatal abstinence syndrome related to alcohol, barbiturates, SSRIs, diazepam. I would challenge that thinking, because if you look carefully at each of the descriptions under each of these drugs, you'll see that they have something in common with neonatal abstinence. There's hyperactivity, there's crying, there's irritability for almost all of them. Barbiturates especially can produce severe tremors. There have been seizures described with SSRIs, and diazepam has also been said to produce a neonatal abstinence syndrome. But if we explore this more carefully, we can differentiate NAS from neurobehavior. Let me just point out, NAS produces many of the neurological signs we've talked about. They're listed here, as do neurobehavioral difficulties. But when you move to the other systems, the gastrointestinal, the respiratory, and the autonomic nervous system, that's where you differentiate NAS from neurobehavior. We did studies about 25 years ago that showed that the diagnosis of NAS is often driven by racial and social class considerations. And we showed in those studies that African American, lower socioeconomic populations are much more likely to have their babies diagnosed with NAS as opposed to infants born to white, middle-class women, especially with insurance, that the infants present exactly the same way. And in fact, in many of the cases, it was documented the mother had used opiates, but those infants are diagnosed with seizure disorders or neurobehavioral difficulties. There are racial and social class considerations here that come into play. Now, why is it important that we not approach our diagnosis this way? It's because the difference between NAS and neurobehavioral difficulties affects the actual treatment of the infants. All infants who have been prenatally exposed who are having NAS or neurobehavioral difficulties, the general approach, the non-pharmacologic approach, is similar. You swaddle the infant, and it's best to swaddle the infant in a flexed midline position. Now, some people call that the fetal position. It's not really, it's a self-soothing position, so tightly swaddled in a flexed position with a pacifier. And studies have shown that sucking on a pacifier raises internal opiate levels. Use low lighting, and if possible, an oscillating crib, and avoid abrupt changes, so going in and picking up the infant suddenly. Now, you can imagine how infants with neurobehavioral difficulties or NAS would do in a NICU with all the flashing lights and alarms. So many hospitals have developed a quieter nursery for these infants. For both groups of infants, NAS or neurobehavioral difficulties, frequent small feedings are best. And then the last step, and here's the important point, we want to use medications only in the cases when absolutely necessary for neonatal abstinence syndrome. You do not want to give morphine, methadone, paregoric, phenobarbital, the medications most commonly used to treat NAS, to an infant with neurobehavioral difficulties who was not exposed to opiates. And even for NAS, it is a last step, and the great majority of infants do not require medication if they are provided the appropriate supportive management. As infants get older, through 3 years of age, I've listed here some of the difficulties that the infants can show over those first 3 years. And if you notice, they all are based to regulatory behaviors. That is the common theme for most children prenatally exposed. IQ is not affected, global cognitive functioning is not affected except by alcohol, but all the other substances, global cognition is completely normal, sometimes perhaps in the low normal range, but in the normal range. Where the children over the short and long-term periods get into difficulties is with the regulatory behaviors. State regulation and arousal, abnormal sleep states, so they never get into a deep sleep, difficulties with habituation, reflexes can be hypertonic as well as hyporeflexive. They have difficulty with self-soothing, and as they get older, difficulty with attention, transitions, and modulation of affect. It is no wonder then that based on these regulatory difficulties, the children often are diagnosed with ADHD. But we published an article just last year that showed the high rate of misdiagnosis in prenatally exposed infants. In fact, we took random sampling from a population of about 3,000 children and then looked at their diagnoses. And what we found is that 85.6% of children with prenatal alcohol and drug exposure were misdiagnosed, and the great majority were on inappropriate medications. If you would like more information, you can contact me through our website. We have a variety of materials there. I hope I've given you some answers today, but I also hope I've raised a lot of questions, because there is a lot of work to do that tells us that we need to do a better job with these families and especially with these infants. So Linda, I'll turn it back over to you. Thanks.
Thank you, Dr. Chesnoff. That's very informative. What we know is that infant mental health consultants are there to support, and what we're talking about today is home visitors, but early care and education people as well, in understanding how the impact of opioids is affecting the babies and the children. So we learned a great deal about relationships and how opioids affect and impair relationships, but also what can we do to help with this. If your home visitor has this information that is shared with them through a training or through mental health consultation, they have a better chance to support the families as they work through these issues. So if they understand the effect and impact, and then they have some ideas and some tools to say, here are some things that we can help you with, such as the management, how to swaddle, use a pacifier, bring the light down, in order to increase their chances of positive social and emotional growth. We have the ability as mental health consultants to be reflective and to be supportive, to listen and then to offer ideas, and together we support those families so that they can have the best chance that the home visitor can offer them. Thank you for joining us, and please visit our website for tip sheets, resources, and more information about infant and early childhood mental health consultation, including how consultants can help address the use of opioids and other substances among families with young children.